Thank you very much, especially for this nice topic, because a re-evaluation means that we have inoperability criteria, and I think they are not so clear. So when talking about this topic, it doesn't go on. Yes, we have to talk about two things. What does it mean, resectability or the borderline resectability? Once from the technical point of view, it's mainly when we have vascular infiltration of other organs or recurrent tumor. And of course, we have to talk about the functional aspect. We have a small remnant, but also if we have poor quality of the liver, it means steatosis, fibrosis, cirrhosis, or cholestasis. And of course, when we think about re-evaluation, it is not the same in each tumor. So it may differ from tumor to tumor. And the question we have to ask every day, even if we can resect, does it make sense oncologically? So this differs from tumor to tumor. And for all the tumors, we have to ask the question, does it make sense to resect if the tumor is invading the vessels or if it is invading other organs? And of course, does it make sense to remove multifocal tumor? One example, this is an intrahepatic cholangiocarcinoma. This was an R0 resection, but I think from the oncological point of view, it's no sense to resect it because the tumor will recur for sure. On the other side, if you have colorectal metastasis, here are 5 metastases. Of course, this makes sense to make a resection because the colorectal metastasis will not recur as aggressive as the intrahepatic cholangiocarcinoma. And here, of course, we know that even repeated resection is sensible. So this differs a lot from one tumor to the other tumor. And here are some examples. Recurrent tumor, borderline resectable because of the functional liver remnant, invasion of adjacent organs, and invasion of hilar or venous structures. So let me begin here. Do we have some data whether we should resect adjacent organs? Here's one example, a gallbladder carcinoma in a 60-year-old patient. The tumor is going down. See here in the middle of the liver. The gallbladder segments 4 and 8 are invaded, also the caudate lobe, but the tumor goes down to the pancreas, and also the pancreas head seems to be involved. This is technically resectable, and we have done it by essential hepatectomy, removed caudate lobe segment 4A, B, 5 and 8, and also did the Whipple operation. You see here the pancreas and the pancreatic duct. This is portal vein, this is vena cava, and here the hilum. It was a gallbladder carcinoma, but of course, if you see the lymph nodes are invaded, L1, V1, so the prognosis is poor. And here are data from the Sloan Kettering Cancer Center. They said, of course, you should resect the gallbladder cancer even if it invades other organs. And here their curves are almost the same if they have resection of another organ, yes or no. But if you look at their data, out of 21 additional resections, only in 10 there was tumor infiltration, and they were almost all node negative. So this does not say anything that the curves are the same. So probably those patients having tumor infiltrations are doing much worse. On the other side, looking at hepatocellular carcinoma, if we have a combined liver resection and GI tract resection, there's hardly any data in literature, only case reports. And taking them all together, you see the patients being treated by surgery, liver resection and GI tract resection, have a better survival curve than those are not treated. But of course, this is patient selection. So we should try to resect, but we cannot say that it gives a better outcome because we don't have any good data. And this brings me to the next point. If the tumor invades vascular organs, or here a tumor thrombus of an HCC going to the atrium, of course, this is technically resectable. We can open the sternum and do a right hepatectomy and also remove the thrombus out of the atrium. So coming to this point, to the vascular invasion, where are the limits, where are the borders? Either we have hilar invasion or invasion of the venous outflow, or both. Let me start with the hilar invasion. This is HCC with the tumor thrombus in the portal vein. And for all of you who do liver transplantation, they all know that it's not a problem to resect this to remove the tumor thrombus out of the portal vein and do portal vein resection. Things become more difficult, for instance, when you go to hyalocholangiocarcinoma. In hyalocholangiocarcinoma, if you have a 3B or 4 bismuth type 4 carcinoma, it's located here, and usually the right artery goes between bile duct and the portal vein, and very often the right hepatic artery is invaded. So in left hepatectomy, this is one problem, that the right artery often is involved, and sometimes it is impossible to resect. And now the Japanese guys have made a suggestion to transpose the left artery or to transpose the gastroduodenal artery to the right hepatic artery. You see it here. This is suggested by Miyazaki. Here the gastroduodenal artery, they can resect it here, transpose it here to the right hepatic artery, and make an end-to-end anastomosis in this way. This is a cetus of an operation I have done. This is the anastomosis between gastroduodenal artery and right hepatic artery. Usually the gastroduodenal, you maybe see it here, this is the pancreas, it should be here, but we cut it here and transposed it here to the right hepatic artery. This is anastomosis gastroduodenal artery to right hepatic artery. And so in Klatskin tumor, even if the contralateral artery is invaded, one can do a resection. And the guy having most experience here is Nagino from Nagoya, and he could show that he had at least a 3-year survival of about 40%, even if he had arterial invasion and reconstruction. So where are the limits in the hepatic hilus? If you have infiltration of both arteries, usually the case is irresectable, but occasionally no, as I have shown now in the Klatskin tumor. Bile duct, if you have hilar bifurcation invasion, this is no problem to resect. If you have contralateral hepatic duct invasion, usually it is difficult to resect. If you have portal vein invasion, it's no problem, and you have invasion of both portal vein trunks to the left and to the right side, this is difficult. I want to show you one case where we could manage invasion of both ducts and invasion of both portal vein trunks. This is a case report of a 47-year-old man with colorectal metastasis. You see one tumor here, one here. He had already 12 cycles of chemotherapy, and even at that moment it was difficult to resect because the tumor was here approaching the left portal vein and was in the right lobe. The patient didn't want to have operation. He wanted to have TARTS first, and he came back after TARTS, and the tumor was now here, very much infiltrating the right lobe here, infiltrating the left lobe here, infiltrating the portal vein, and you also see the dilated bile ducts here on the left. This is left lateral. The tumor goes far to the left lateral, and all 8 segments are involved, and the left portal vein is involved, and the left duct is involved. To resect it, we would have to cut here, as the red line shows you, and we would have to reconstruct the portal vein and the bile duct. The remnant volume was 27%. This is 3D reconstruction showing that the left hepatic artery comes from the left gastric artery, so at least the left hepatic artery was free for sure. And the patient then wanted to have the operation, and we did a real extended right hepatectomy. We removed segment 1, we removed all the segment 5 to 8, and partially segment 2 and 3. We resected the portal vein, made an end-to-end anastomosis using a saphenous venous graft here, and we did resection of the hilar bifurcation, you see it here, and the Roux-en-Y reconstruction, and this was an R0 resection, and the patient survived for almost more than 2.5 years. So coming to the next point, the invasion of the hilar, of the venous structure of the liver venous outflow. Sometimes we have tumors like this. This is intrahepatic cholangiocarcinoma, but we can manage it by cooling down the liver, resecting the vena cava, and reinsertion of the right hepatic vein, as we have done here. And sometimes, if we need a lot of time to clamp the liver, and then it may be helpful to cool down the liver. And we have 3 different forms of extended hepatectomy with veno-venous bypass. It is the in situ cooling, shown here. We just clamp the liver, we clamp the hepatic hilus, and cool down the liver in the situs. It's the ante-situ resection, is clamping, as I have shown for the in situ, but also cutting the vena cava. Then you can rotate out the liver, out of the situs, and you have a better approach to the suprahepatic vena cava and to the liver veins. And we have the ex situ liver resection. There we take out the whole liver, do the operation or resection of the tumor at a bench, and then we do a retransplantation of the remnant. This we have done in former times very often, but we don't do it now because morbidity and mortality is really high. It's about 30%. This is very nice, but you have to do Havel vein anastomosis, and we try, if we have to do, we try to do the in situ cooling because we don't need an additional vascular anastomosis. And twice or 3 times a year we do such an operation. For instance, in this tumor where all 3 veins are invaded, we cool down the liver, and here it helps also to do 3D reconstruction and computer-assisted operation planning, as you can really make operation planning at the computer and calculate the remnant liver volume. Or if you have invasion of the vena cava and all 3 veins, like here, this is the in situ cooled liver. It's the vena cava here in the left hepatic vein, and here the reanastomosis, and this is the specimen. So coming now to the recurrent tumor, we all know that in colorectal metastasis, it is standard to do repeated hepatectomy for recurrent colorectal metastasis. For other tumors like HCC and CCC, there are only rare data, and this is an intrahepatic recurrence of cholangiocarcinoma. You see it here. It was 3 years after right hepatectomy. Now the tumor is approaching the left hepatic vein, the only vein, and we could resect it again, also resect a little bit part of the vena cava. And there is increasing data in literature that also in intrahepatic cholangiocarcinoma, repeated resection is of value for the patient in case you get an R0 resection. Coming to the functional critical resections, we all know that liver failure is the main risk after hepatectomy, but it's not only the liver volume, the remnant volume, that may be crucial for liver failure. It's also patient-related factors like age, diabetes, obesity. It's the liver-related factors, cholestasis, steatosis, and of course the surgery-related factors, massive bleeding, liver ischemia, and so on. And it's also a matter which kind of resection you do. Extended right hepatectomy or extended left hepatectomy. In extended left hepatectomy, the remnant volume usually is much bigger, often double the size than in extended right. But morbidity and mortality in extended left is also double. So it's not only the volume of the remnant, it's also the kind of surgery. Here we have a much bigger cutting surface. Here we have much more risk for biliary leak. So it depends also on the type of surgery. You all know that we have some measures to increase functional resectability. It's the 2-stage hepatectomy, it's the portal vein embolization or ligation, and a new technique, the in situ split, or called ALPS. Here are some data from literature after portal vein embolization and portal vein ligation. You can get about 30 to 50% of volume increase, and you often have to wait between 3 and 10 weeks after ligation or embolization. This is sometimes too long waiting time or sometimes not enough volume increase. Here, for instance, one example why portal vein ligation probably might not work in some cases. This is portal vein transection. It's 8 weeks after transection of the portal vein. There should be no right portal vein, but of course by collaterals the right portal vein is still perfused, and so it is not working in all cases. The new operation, the in situ split or ALPS, was initiated by Professor Schlitt from Regensburg almost 8 years ago. And this is my first case of in situ split. It was a young lady with an intrahepatic cholangiocarcinoma. The tumor is in the right lobe. You see here the dilated left bile ducts. I wanted to have a portal vein embolization, but the radiologist refused to do because they said the portal vein on the left side is already invaded, so they didn't do. And so I went on for an in situ split. The volume was 400. This is after in situ split. The left lobe, it's 1 week after in situ split. The portal vein was not invaded, and I had already done a Roux-en-Y loop to the left intrahepatic duct. After 1 week, hypertrophy of 75%. This is what we can get about in 1 week. This is completion operation at day 8. Here you see the specimen. You see here the left lobe. It's no more jaundiced. It's huge, but no more jaundiced. Here after resection of the right lobe. And the patient got intrahepatic recurrence 2 years after the in situ split. We did a repeated hepatectomy, and she is now almost 5.5 years after the ALPS procedure without recurrence in very good condition. And I think this is the patient being alive for the longest time after in situ split so far. Another picture of an in situ split. You see here the divided liver, the cable vein, the left, middle, and right hepatic vein. And here are a comparison of in situ split and portal vein embolization. The in situ split is more effective with regard to resectability. If you start the first operation in situ split, then almost all patients will come to the second operation. So if you start it, resectability is almost 100% in situ split, where you have the portal vein embolization. And in portal vein embolization, you have about 20% patients not coming to the resection because of tumor progression during the waiting time. So in situ split is more effective regarding resectability. And from the oncological point of view, of course, we have not enough data, but it seems to be the same, portal vein embolization and in situ split. So oncologically, maybe the same, but in situ split more effective with regard to resection rate. So finally, I think the tumor entity where we can best say where are the borders of resectability or where we have new criteria is colorectal liver metastasis because of chemotherapy. In colorectal liver metastasis, there has a real shift of the resectability criteria. The Americans already say that it's a shift of paradigm. They said in former times we just looked at the number and size of liver metastasis. We looked at extrahepatic tumor and safety margin of 1 centimeter. When I was a resident, we were always told you only need to resect colorectal metastasis if you are sure that you can achieve a safety margin of 1 centimeter. And this is no more true today, not at all. And now the new definitions from the American, they say you just need an arterial resection and you just need to look at the remnant volume, and if it's big enough, then you should go for resection. I think this is too far, to go too far, because of course a resection has to fit into an oncological concept, and the arterial resection we need not question, but an R1 resection is not so bad as we have thought in former years. And there is one very nice paper from the United States, and the same things have been shown by other groups. It doesn't matter whether you have a larger or smaller resection margin. 1 millimeter is almost the same like 10 millimeters. And even if you have an R1 resection, then you have not so poor results. Why? Because we have very good and very effective chemotherapy nowadays. And of course, we burn the resection surface of the liver, and so sometimes an R1 resection, that means only that tumor is in the specimen, at the border of the specimen, but it needs not to be within the liver. So R1 resection is no disaster, although of course arterial resection is our aim. And when you know, or if you know that you only need 1 millimeter, then of course you can also resect tumors like this in the hepatic venous confluence close to the right and left hepatic vein. The radiologists always say us a tumor is invading right hepatic vein, vena cava. In colorectal metastasis, the major hepatic veins are hardly invaded, and you can resect this. You see it here. This is vena cava, right hepatic vein, left hepatic vein, and this is the specimen. It was also an R0 resection. Even the middle hepatic vein was not invaded. Now coming to my last point, it's the oncologically questionably resectable tumors. If you have multiple of metastases, we can resect them, but should we do? And we all know that we have not only the two-stage hepatectomy, the portal vein embolization, ligation, or better operation planning, but in colorectal metastasis, we also have the reduction of tumors, the downsizing of tumor by chemotherapy. And this is very effective in colorectal metastasis. And this is the case I've shown you yesterday of the video. It's large tumor bulk in the liver, downsizing by chemotherapy, then doing a secondary operation of the liver. And if you combine two-stage hepatectomy and neoadjuvant chemotherapy, you are very effective in resection of colorectal metastasis. And one nice paper, and this is my last but one slide, again coming from the United States, where they did downsizing chemotherapy and two-stage hepatectomy, and they combined it with chemotherapy, because it's very often argued that people say those cases you resect are the better cases and the poor cases you leave for chemotherapy, and so it's only patient selection that you have so good data in liver resection. What did they do? They did two-stage hepatectomy and downsizing chemotherapy in 47 cases, and these are the results of this approach. It's very good data from the MD Anderson, 60% 5-year survival. So this is very good, and of course patient selection. And this is the curve of chemotherapy, 62 patients. So this curve is much better than that curve. The worst curve is of those patients who started two-stage hepatectomy, did the first resection, but did not complete the two-stage hepatectomy. Now let's have a closer look at this curve, 62 patients. This is 62 patients out of initially 879 patients with metastatic colorectal metastasis. Then the guys excluded all patients having extrahepatic tumor. Livers only were 425. Then they excluded all patients who did not survive for more than 1 year or did not respond. Only 207 patients were left. They excluded the patients older than 70 years and in the poor performance status. And they excluded all patients having inoperable metastasis. And finally, 62 were left. These are the best candidates of 800 patients with chemotherapy. And this is the curve of those 62. And certainly it's not a study, a prospective study, but this shows you the value of liver resection in colorectal metastasis. It is more effective than chemotherapy only. And I think in colorectal metastasis, we should push our borders of resectability as far as possible, because this helps the patient. This was my final slide. Thank you again for your attention, and again, a hint to our Congress in 2 years in Mainz. Thank you very much.